All right. Hello, everybody. My name is Kenneth Mueller. I'm a pharmacist and faculty over at Emory University School of Nursing. So today's topic is going to be sleep, health, and pharmacology. So here's my official disclosure slide. I have nothing to disclose as far as any conflict of interest or commercial interests. So the lecture objectives today, I'm going to go over some common or at least concerning conditions to me that have negative influences on our sleep health. And specifically, I want to talk about a couple drugs that many of us are familiar with, that many of us use on a day-to-day basis or perhaps weekly basis that actually have negative influences on our sleep health. Briefly, I'm going to list several national associations or organizations that have published guidelines or statements about sleep health and management. And I'm also going to go through some pharmacological drug classes recommended in the treatment of insomnia. And then briefly, we'll identify an example of social determinants of health on the influence of women's health in regards to pharmacology. So, and I'm actually going to set a timer for myself too, just keep track of my time. So excuse me there. There we go. Okay. So as far as sleep, look, sleep is critically important, and there are lots of risks associated with short sleep or insufficient sleep. So I've got a couple of things listed here for you that are conditions or diseases that we might see. Diabetes, cardiovascular disease, this includes hypertension, stroke, obesity, depression, arthritis, cancer, asthma, COPD, chronic kidney disease, and lots of other examples out there too. Two significant things that always jump out at me when I think about sleep and its importance and conditions that exacerbate or, of course, reduce our sleep and quality of sleep are night shift work and daylight savings time. So night shift work, there's actually a couple different organizations out there that define night shift work as a probable carcinogen to humans. And there was one group, there's a publication rather, in 2009, it was Danish night shift workers with breast cancer awarded compensation. So there were actually 38 women who were night workers who developed breast cancer, and they really didn't have any other underlying markers. They didn't have heavy alcohol consumption, and Denmark actually awarded them compensation for night shift work with association with breast cancer. So it's clear here that, again, looking at night shift work, we're seeing associations with the increased risk for cancer. And unfortunately, many in healthcare have to put in their time and do those night shifts. Another big one is daylight savings. So we all know daylight savings, and you fall back and you spring forward. And this to me is always is just a big eye opener. And we see all sorts of different studies pop up all the time. But this one here, the first one, was in 2018, and it showed AFib or atrial fibrillation hospital admission rates increased the day after daylight savings time. There was a Michigan study in 2014 that showed an association of a 25% increase in myocardial infarctions on Monday following daylight savings time. And that same study then showed a 21% reduction in myocardial infarction on Tuesday after the fall back or the gain of an hour of sleep. So again, associations here, not necessarily causations, but to me, we have so much repetitive studying of sleep, and this is just a big example of reducing 1 hour of sleep, what we're seeing, and then gaining an hour of sleep and the reduction there. There are lots of other studies out there too that show a wide variety of other situations with reduced sleep, such as injuries, car accidents, you name it. And not to get too far off topic, but there's even studies in children and our middle school, high school students, and even grade performances and scores on standardized tests with reductions in sleep, and then flip controversially with gains of sleep and those test scores. So moving on now from the direct risks of sleep, I wanted to talk about, of course, pharmacology and talk about two drugs that many of us are familiar with. These two drugs are caffeine and alcohol. And these two drugs, and we should define them as drugs, the United States consumes these in heavy quantities. So let's talk first about caffeine. So caffeine is the most widely consumed psychostimulant in the world. And I don't know about you, but I'm a fan of Starbucks. And Starbucks is actually found in over 80 different countries with roughly 15,000 stores in the United States alone. In North America, it's estimated that around 85% of the US population consumes at least one caffeinated beverage per day. That mean daily caffeine intake was around 165 milligrams of caffeine. And, we always think of coffee, of course, but caffeine can be found in a wide variety of other substances and beverages. We have, very large consumption of just energy drinks. There's Red Bull on our Formula One cars now, teas, green teas. There are some caffeine-free teas like hibiscus, but many teas do have caffeine. Coffee, of course, your soda. We're here down in the South. So Atlanta, Georgia, Coca-Cola, we do have caffeine in many of our products. So it's important to remember that it's not just coffee alone. So now, what's going on with caffeine and sleep exactly? So, we know we drink coffee or caffeine with the intent to stay awake and alert. So what's the mechanism behind coffee, or really the caffeine, which is the active ingredient? Caffeine is actually an antagonist at adenosine receptors. So adenosine, if you work in the clinical setting, you probably have heard of course, adenosine pushes for SVT or other conditions, but adenosine here, for this focus in the brain, it's a vastly complex neurotransmitter. And so in the brain, we do know it promotes sleep and suppressing arousal. And so it starts to build basically throughout the day. So, throughout the day, it grows and grows and grows. And so we get sleepier and sleepier and sleepier. Caffeine is an antagonist of adenosine. So within the brain, it of course alerts us. And then if you think of the heart, for example, adenosine normally suppresses the pacemaker role. And then of course you drink a little bit extra coffee, and what happens? Our heart starts to pound a little bit more. So caffeine is the literal opposite of adenosine. Another drug that would actually fall into a derivative of this class are those methylxanthine derivatives, like theophylline, if that old school drug rings a bell for you. But the reason why I like to talk about caffeine is not only is it keeping us awake, which is again why we drink it, but we have to recognize that it's got a half-life of about 5 hours. And so this helps put it into perspective, at least to me, of why drinking a cup of coffee, potentially later in the day may cause problems trying to sleep that night. So caffeine's half-life is roughly 5 hours. This was just taken from Lexicomp as far as that half-life population point. But imagine a patient who drinks a cup, or one of us drinks a cup at 10 a.m. So you drink one cup of coffee, 10 a.m. Half-life goes by 5 hours later, and I've got it written out for you there. But 1500 or 3 p.m., one half-life has gone by. You now have half a cup of coffee still in your bloodstream, still kicking in the brain. Another 5 hours goes by, and boom, it's 8 p.m. at night, 2000. You still have a quarter cup of coffee floating around the blood, working on your brain. Another half-life goes by, another 5 hours. It's now 1 a.m. You're trying to sleep, and you still have an eighth of a cup of coffee kicking in. Well, depending on how you are throughout the day, maybe for lunch, you had a can of soda, or you had a tea, or maybe you had another cup of coffee in the afternoon. You can see how just multiple consumptions of caffeine throughout the day is going to, of course, alter this pure just elimination alone. And now we're going to have another spike in concentration, which is just going to prolong the amount of caffeine in our bodies. So it is important for us to recognize that, again, caffeine is this heavily consumed product. And as we talk about sleep here and insomnia and other sleep complications, before we start throwing drugs at our patients, let's look and see what they're currently taking. And, one important cornerstones of sleep hygiene of sleep health is sleep hygiene. And so that's reviewing, not to get too far off topic again here, but of course, your consumption of caffeine. We're going to talk about alcohol in a second, blue light exposure, and many other factors. So before we get into pharmacological treatment, at the end of the day, we've got to focus back on square one, which is sleep hygiene. So caffeine was the first drug example to be cognizant of. And the second example is alcohol. So alcohol is defined as a psychotropic depressant on the central nervous system. And just like caffeine is also used extensively in the United States and throughout the world. This recent 2021 Gallup poll reports that it's estimated around 60% of US adults drink alcoholic beverages. As far as the consumption frequency, that's a little bit different. Americans average anywhere, their weekly number of drinks is roughly 3.6 alcoholic beverages. And so I put this graph, I'm not sure how well you can see it, but this kind of shows over time consumption of alcohol in the United States. And so it does fluctuate up and down, but it seems to be overall pretty consistent. But the reason why we talk about alcohol is a lot's still unknown on the influences of alcohol and sleep, but we do know a couple things. Number one, we know that alcohol can suppress REM sleep. And this creates an imbalance in your sleep and your decreased overall sleep quality and duration. So for me, when I think about that, I just think about myself with, using alcohol socially or recreationally is, sure, I pass out, right? I sleep well. I shouldn't say I sleep well. That's contradictory to what I'm trying to tell you, is that I pass out, right? I fall asleep fast. It is a sedative. You fall asleep fast. However, that quality of sleep is poor. Usually, again, you're out hard. And then in the early hours of the morning, usually your body's playing catch up from that suppressed REM sleep. And you may notice, at least in my own personal anecdotal experience, is that usually in the early morning hours, I have these crazy vivid dreams where my brain is literally trying to catch up with that lack of REM sleep throughout the earlier hours of my sleep. And so alcohol does, again, suppress that REM sleep. And we do know that alcohol also increases the risk of sleep apnea by 25%. So again, working on the brain and that sleep quality, as well as the sleep apnea indirect, which also has a poor outcome on sleep quality. And what I wanted to focus on and talk about, which helps us in regards to understanding our pharmacological agents, is alcohol binds to the Gaba receptor. So let's look at the Gaba receptor. The Gaba receptor, the GABA A receptor specifically, is found, quite in robust numbers throughout the central nervous system. And I always think of the GABA receptor like a glove. There are multiple targets, and so I think of that like fingers, or if you want to use this cultural meme of Thanos from Marvel: The Avengers. If you haven't seen it, very good movie. But looking here at Thanos and his glove, you can see that there's multiple different colors, which is, to me, visualizes the GABA receptor, and that there are multiple different drugs or neurotransmitters that can bind to this GABA receptor. So a quick refresher is GABA is an inhibitory neurotransmitter, which is what causes sedation in the body. And so you can see here, looking at these various different things that can activate the GABA receptor, we have alcohol as one of those products. Barbiturates or barbiturates, which is the oldest sedative out there, can also activate this same receptor. BZDs, which are your benzodiazepines, like your diazepam, which is Valium, or your alprazolam, which is Xanax, can also activate these receptors. And then your benzodiazepine-like drugs, which we're going to talk about here briefly, are drugs like your Ambien, which is your Zolpidem. And so all of these agents can activate the GABA receptor. And the GABA receptor, what this does is it's an inhibitory neurotransmitter. And so briefly, it allows these chloride ions, if you can see them, you can see that they're anions, negatively charged. And so what they do is they have an influx into this particular cell, which hyperpolarizes it, or this neuron hyperpolarizes it, and therefore it causes a delay in action potentials, which essentially is sedation. So whether it's alcohol, whether it's a benzo, so an Ambien, a benzo-like drug, they're all kind of working at this same area, which is why we say alcohol knocks us out, it's a sedative, but these other agents are also sedatives. Oops, forgot I had that stimulated there, and that's where GABA naturally binds. Okay, so now that we went through kind of a brief history there of like a couple of risk factors associated with sleep hygiene, we talked about night shift work, we talked about daylight savings, and of course how important sleep is. And then we talked about two drugs that are commonly used recreationally or in a daily the life of caffeine and alcohol that impacts on our sleep, let's now actually talk about management of sleep. So there are multiple guidelines out there for treatment of insomnia, and they all have their own established guidelines on the different type of sleep concern, sleep apnea, chronic insomnia, pediatric, adult, et cetera. And so, these are different ones out there that are suggested for you. And this remainder portion here of this lecture is not intended to help diagnose or manage sleep, but we're going to have an overview of pharmacological agents that are used in insomnia and other sleep-related disorders. Again, it's hard to summarize all those different guidelines into one thing. So I'm going to give you an overview of the common groups that you'll see. And so ultimately, sleep is extremely complex. There's a wide variety of sleep-related disorders. Is it difficulty falling asleep, difficulty maintaining sleep? So with all these variations, at the end of the day, I just want to give you an overview of the pharmacological options out there. And so a big important reminder is that guidelines always state this first, is that for insomnia, the first line recommendation is cognitive behavioral therapy for insomnia. So one more time, the guidelines do not recommend drugs first. They recommend cognitive behavioral therapy for insomnia. This ties back to sleep hygiene. If somebody's consuming vast quantities of caffeine, if they're drinking alcohol, of course, the drugs are not going to be sufficient. The pharmacological prescribed drugs are not going to be appropriately managing this sleep if we're not going back to square one and looking at sleep hygiene. This also includes things like late night looking at your cell phone, or right now I'm looking at a laptop. These are all blue lights. The lights above me are blue lights. These, of course, also can inhibit our body's natural production of melatonin too. So sleep hygiene is square one with cognitive behavioral therapy. So let's go into agents that you probably have commonly seen or may see, especially coming up with this newer, I should say, Orexin receptor antagonist group. So we have benzos, which is a common one that we see. Also the benzo-like drugs, and then the orexin receptor antagonists. And due to time constraints, we won't have time to discuss some of these other agents listed here, although you have commonly seen them or will commonly see them used for sleep. So the first class I want to talk about are these benzodiazepines. So benzodiazepines are a very large group of drugs, commonly referred to as benzos or BZDs. Sometimes you'll hear them called Z drugs, although really the benzo-like drugs are really more so the Z drugs. And I oftentimes call these PAMs or LAMs, since that's a pretty common suffix that tends to catch most of them. And example drugs here, again, are prazolam, which is Xanax. And if you look at alprazolam, I've got the Z kind of bolded to remind you it's almost a Z-like drug. And then the suffix there is lam, so alprazolam. And then diazepam, the Z is bolded and it ends in PAM. So again, PAMs and LAMs are a pretty heavy common suffix in this group. This drug class is used for a wide variety of indications, including seizures, insomnia, our topic right now, anxiety. Diazepam can be used for muscle spasms. We can use these for alcohol withdrawal, which hopefully makes sense because we said that alcohol binds to the Gaba receptor. And that Gaba receptor, meaning, remember, it's a glove. It's got those 5 fingers. The GABA naturally binds to that GABA receptor. Alcohol can bind there, and benzos can bind there, which is why benzos can be used for alcohol withdrawal. So, excuse me, as far as its mechanism, these benzodiazepines as a class, they bind to those GABA A receptors, which again, GABA is an inhibitory neurotransmitter. And so when benzos bind the GABA receptor, remember, it allows this chloride influx, which chloride is an anion, which hyperpolarizes this neuron, which is going to basically have an inhibitory effect. And so again, if you look at this picture, you can see, again, 5 targets, just like the glove or the different fingers there. And you can see these different agents, neurotransmitters, or drugs that are going to bind here. So benzos, as I mentioned, there's a large quantity of them. And so when you think of sleep, if these are used, hopefully you're seeing short or intermediate acting agents used. These agents are based off their half-lives. And so in of course, the healthcare world, we always love our little acronyms and mnemonics. And so I've got a couple here you may have heard, or maybe you haven't have heard, just to help you remember when you see these agents, if they're being used for sleep, which ones are being used. So hopefully you're seeing short or intermediate acting. And so the short little mnemonic there is ATOM. So alprazolam, triazolam, oxazepam, and midazolam. And I'm not going to read all of these off to you, but ATOM, those are your short-acting ones. And look at that midazolam, Versed, which is pretty heavily in the news as of late with Redondavot, with that trial. But intermediate acting, these are going to be a little bit longer acting. And so we actually where I work clinically at the hospital, we have one of these on the formulary, which is kind of the go-to for if needed for short-term sleep issue. And these are, the mnemonic here is TLC, temazepam, lorazepam, or clonazepam. So hopefully those are the agents that you're seeing. If you're seeing these used still, that you're seeing either a short or intermediate acting agent. The longer acting agents, as you can imagine, you'd have much higher risk for some sort of hangover effect, or again, a delayed, prolonged effect the next day with perhaps some sedation. The long-acting agents, the ones I see used, chlordiazepoxide, diazepam, those are ones I see oftentimes for a CWA alcohol withdrawal order set. So with these benzodiazepines, again, some of the guidelines actually do not recommend these, but if you're seeing them used, we just talked about the short or intermediate acting. Another concern would be if you're seeing these used, another consideration pharmacokinetically, besides just the half-lives, would be to consider their pharmacokinetic effects regarding metabolism. So all benzos do go through the liver to some extent. And these three here, this lot, if you will, this mnemonic, these are three that have minimal metabolism. And so they're the safest or most recommended in patients who have liver concern with liver disease, or geriatric patients perhaps. And so again, lorazepam, oxazepam, and temazepam, again, where I work clinically, temazepam is that agent that is sometimes used. So these agents, these benzo agents, just like with alcohol, they are sedatives. And so a friendly reminder that we have to be careful with drug-drug interactions. And so the drug-drug interaction rule that I've kind of created and used for my students is the B and Z rule. So I always tell everybody to remind them not to mix B's and Z's together. And the risk, of course, could be profound sedation and respiratory depression. So the B and Z's, I've got kind of listed here some of the ones that at least jump out to me. Shouldn't mix your benzodiazepines with back pain relievers or relaxers like cyclobenzaprine, as an example. With booze, obviously, you don't mix a benzodiazepine with booze, alcohol. Don't mix benzos with other benzos. Don't mix them with your other PAMs and LAMs. Don't mix them with benzo-like drugs. So your Ambien, which is Zolpidem, which starts with a Z, those are your benzo-like or Z drugs. Your barbiturates, which all have barb, so barb rather, so phenobarbital. You actually have tol as a common suffix. So phenobarbital, methohexatol, pentobarbital, there's a couple examples there, but those are mainly, again, sedative agents. And then big time opioids like morphine, for example. And then Benadryl, meaning diphenhydramine, which is a first generation sedating antihistamine. And then I put botanicals. Sometimes people will use Valerian as an herbal, or Kava as an herbal type sleep medication. And these, again, in conjunction or in combination with any of these other B or Z type agents, could potentially cause some CNS sedation and respiratory depression. So I always like to remind people that even though an agent is listed as an herbal, I always remind people that herbals, although people say they're natural, they still have a risk or potential risk of drug-drug interactions or other considerations. So prescribing reminders for this group, these benzodiazepines, we do see a tolerance and dependence potentially develop, just like with chronic alcohol consumption. And withdrawal can be seen in as low as 4 weeks of usage. So it is important to be careful with these agents. Now, benzodiazepines have abuse potential, and so they are listed in the DEA Controlled Substances Act as Schedule 4 substances. And as I just mentioned with that B and Z rule, these are CNS and respiratory depressants. As I mentioned earlier, you typically would look for a short-acting or intermediate-acting agent because you do have this risk for a hangover effect where somebody may still have are at increased risk of adverse drug reactions and generally not recommended to use these agents. It's actually a Beer's criteria, as well as some of these sleep guidelines do not recommend benzos for sleep in geriatric patients. There's concerns for falls, fractures, and delirium, or kind of the big three. However, realistically, we still see these used in that patient population, even though it's not recommended. So the FDA has 3 boxed warnings for your benzodiazepines. We have risks for use in combination with opioids, which ties back into that B and Z rule that I just told you. There's abuse, misuse, and addiction potential, which ties into the fact that, again, these are Schedule 4 DEA controlled substances, and dependence and withdrawal reactions. We know that with chronic alcohol consumption, sudden withdrawal of that alcohol can cause seizures. And so going back to your pathophysiology very briefly, when you have agents that activate the Gaba receptor and you start inhibiting the brain, because that's what you're doing, Gaba is inhibitory. If you start enhancing that inhibitory effect, whether it's with alcohol or with benzos, the brain starts to try to maintain homeostasis. And so it tries to go back to balance. So right now in the present state, the brain has extra inhibitory effects due to GABA plus a benzo or plus alcohol. So the brain compensates and adjusts by making more glutamate, which is an excitatory neurotransmitter. So the brain is in a constant balancing battle between GABA and glutamate. And so imagine a patient who's been using alcohol for a long time, or has been using benzos for a long time, and they're developing a tolerance, and you're giving more and more alcohol, more and more benzos. The brain, to compensate, is making more and more glutamate, which is excitatory. Now, if you take away the alcohol, or if you take away the benzodiazepine, that balance becomes lost within the brain. It loses the GABA and its other inhibitory drugs, and now you have the brain still making all this excessive glutamate, which can cause seizures. So again, the withdrawal reactions, I'm mainly thinking about alcohol, and of course, your risk for DTs and seizures, of course. But benzos, if somebody's got high chronic dosages and you take that away, or especially if you reverse a benzodiazepine with the antidote flumazenil, we do have a risk for seizures too. So that was your summary for those benzodiazepines. Let's now jump into these benzodiazepine-like drugs. So these agents here are working at the GABA receptor. However, they're not working in the same manner that your benzos work in. They have a slightly different mechanism. And so we call these benzo-like drugs. So you'll hear them called benzodiazepine-like drugs or non-benzodiazepines. They're still classified as sedatives or hypnotics. Some will call them non-benzodiazepine receptor agonists, or these are commonly referred to as your Z drugs or your Z drugs because they all have Z in the name. And the most famous common example, of course, is Ambien, which is Zolpidem. And so unlike the previous agents, we can only focus here on sleep with these. So these are only for insomnia. The benzos, again, can do things like anxiety, seizures, and sedate you. These are only for sleep. So the mechanism here is similar to benzos, however, not at 100% the same as benzos, which is why they're called benzo-like drugs. So again, going back to the GABA receptor, like Thanos with his glove or his fist, with the 5 fingers there, those are the 5 different potential targets for the GABA receptor. GABA combined, alcohol combined, the barbiturates combined, your benzos combined, and your benzo-like drugs can combine or combined there as well. So your benzo-like drugs will bind to the GABA receptor, However, they only work at what's known as the benzodiazepine 1 receptor. So again, they function like benzos. However, they don't bind to all the benzo receptors. They only bind to the benzodiazepine 1 receptor, which is why it's used for sleep. And that's also why you will not see a benzodiazepine-like drug, like Ambien, for example, Zolpidem. It won't adequately cover somebody who has like anxiety or anti-seizure effects. So again, it's not a benzo where it's not going to prevent seizures. It's not going to prevent a panic attack, and it's not going to have like the diazepam muscle relaxant properties. This only works with Ambien here, Zolpidem, at the benzo 1 receptor. Some of them may have a little bit looser affinity, may bind to the benzodiazepine 2 receptor. However, Zolpidem is dominant at the benzo 1 receptor, only for, again, the sleep effect. So prescribing reminders is that these benzo agents can also develop tolerance and dependence. Excuse me. However, you don't really see the significant withdrawal episode like you would with a benzo, because those benzos are binding to more than just the benzo 1 receptor. Again, benzos can be used for seizures and other effects. And so withdrawing from a benzo is harder arguably than withdrawing from a benzo-like drug. So you could still have tolerance and dependence. There's still abuse potential. So these are still labeled as DEA Schedule 4 drugs. There is still CNS respiratory depression. And I should note that respiratory depression is pretty rare on the oral doses at normal doses. This is only usually seen in combination with the drug-drug interaction of your B and Z rule. So remember that the B and Z rule drug-drug interaction still plays into effect here. And older adults are at increased risk of adverse drug reactions. And these are also generally not recommended because there's a concern for falls, fractures, and delirium with this drug class as well. So the boxed warning here, rather than 3 with the benzos, there's 1 here from the FDA for this drug class, and that's complex sleep behaviors. I think we've all seen the news. I think Tiger Woods is the biggest example I've seen where, there's a Hollywood celebrity. It's publicized where they had some sort of erratic behavior and they were driving the next day or something. So complex sleep behaviors, there's a wide variety of things going on. You hear about, again, sleep driving, sleep food consumption. And so one big area that I want to talk about is the history of Ambien, Zolpidem with women's health. So Zolpidem was approved for use by the FDA in 1992. It was 1 year later in 1993 when the National Institute of Health, the NIH, passed the Revitalization Act, which called for increasing the inclusion of women and minorities in clinical trials. So remember, Zolpidem, Ambien, was approved 1 year prior to this and was not extensively studied as well as it should have been, arguably, in women. And so there were decades of post-marketing reports showing adverse effects in women, increased cognitive defects given the standard dosage. And after enough post-marketing reports, in 2013, the FDA informed the manufacturers the starting dose of Zolpidem in women should be lowered. And so there was actually a study by Zucker in 2020. And Zucker and his group, they identified 86 drugs with significant sex differences in pharmacokinetics. And so this goes to show that Zolpidem was one of these drugs that slipped through the cracks and unfortunately led to some severe complications in women. And so some of the recommendations of that 2020 study include drug labeling, and the FDA should provide sex differences, including adverse effects in pharmacokinetics. They should work on study design and study approval process to appropriately look at sex differences and encourage appropriate education and training for healthcare providers in understanding potential sex differences in drug treatment. And so these pharmacokinetic studies or differences, are potentially broad. And so again, there is a call here for further studying with the sex differences. And so ultimately, the lack of inclusion of women and minorities is an example of social determinants of health within the scope of pharmacology, specifically with the lack of policies in place for adequate studying of drug therapy in our vulnerable populations. And so I think what I wanted to take away from there is this won't be the first, and this won't be the last that we hear about where we have drugs and seeing biological sex differences in dosages in future recommendations. So our last final drug class, as we run out of time here, is the dual orexin receptor antagonist called DORAs. And so I put Dora the Explorer, since this is, and if you don't have children, what's Dora the Explorer, who's a famous cartoon character who's known for exploring. And so this is a new class of drugs. I say relatively new, within the last 2014, so the last 8 years that these came out. But it's a newish drug class, and so it's a new cornerstone of insomnia and sleep therapy. And so these agents here, you can identify them by the common suffix of rexant, because these are orexin agents. They again are antagonists, commonly referred to as either DORAs or ORAs. So either orexin receptor antagonists or dual orexin receptor antagonists, which is all based off of, again, its mechanism, and which we'll talk about that in a second. But we actually had the newest one come out this year. And then so it's daridorexant, which makes me think of Doritos. And so suvorexant is the oldest one, which makes me think of a sous vide. So either I'm hungry or they're coincidentally naming these all about foods or food-related topics. But these agents here are for insomnia, so for sleep onset or sleep maintenance. The mechanism for these drugs is, again, as I mentioned, called DORAs, like Dora the Explorer. So new drug class. These orexin neuropeptides were discovered over 20 years ago, so kind of newer pathway here. And there are actually two receptors, orexin 1 and orexin 2, that these agents block. So again, these are antagonists. Orexins A and B are these neuropeptides, which are produced by neurons in the brain in the hypothalamus, with projections to the wake promoting regions within the brain. So orexins A and B essentially are wake promoting neuropeptides. So antagonizing the receptors then can help with the sleep. So that's where this new novel kind of pathway comes into play. So looking at these new agents, you can see the oldest one had a half-life of 12 hours. The newer one, limborexant, has a half-life of roughly 18 hours. And the newest one, daridorexant or Doridorexant, has a half-life of roughly 8 hours. So this newest one, shorter half-life, so likely you probably might be the new go-to one, sort of like those benzos where we have these long-acting benzos, intermediate and short-acting. It makes sense to use intermediate, short-acting benzos if they're going to be used. I can foresee here in the future that probably the daridorexant, due to the short half-life, will probably be the preferred agent. And so again, daridorexant, the newest one here, is an agent that was shown to have objective and subjective measurements and improvement of sleep. So it was found to significantly improve latency to persistent sleep, found to significantly improve wake after sleep onset. So those are two objective measurements. And then the subjective one was that it was found to significantly improve subjective total sleep time. So the researchers, here's their quote, is improvements in sleep variables were achieved without excess sleepiness the following morning, and improvements in daytime functioning were observed. The improvement in sleep perceived by participants in these studies was consistent with that objectively measured by polysomnography. So last final notes here with these DORAs is the most common adverse effect with this drug class includes nasopharyngitis, headache, somnolence. These are Schedule 4, just like the other agents that we've discussed. No evidence of withdrawal here. They do not appear to carry risks of respiratory depression. However, at this time, it's still a good idea to avoid any combinations of any other CNS sedating drugs. So that B and Z rule is still kind of holding relevant here. In clinical trials, the adverse effect profile of suvorexant was generally consistent with that in non-elderly. So sounds like, based off the previous agents that we discussed, your benzos and benzodiazepine drugs, benzodiazepine-like drugs, those are found on the Beers list, not recommended in that population. maybe this drug class could be the new pathway for the geriatric population. Many still urge caution in geriatric patients as there's still a lot of unknown, and of course, more time is always needed with drugs. But a study in 2020 compared one of the newer agents versus placebo and Zolpidem and found that lemborexant causes less postural instability than a commonly used sedative hypnotic and does not impair the ability to awaken to auditory signals. So again, more studies needed, of course, but sounds like this might be the safer alternative. So final notes, we didn't have enough time to, go through all the different drug classes. There's so many, and you didn't want to cut any time short and do anything an injustice. But I wanted to leave you with a couple final notes really quick. There's a couple of small studies out there showing associations between the use of hypnotic agents and the risk of cancer. And so the question kind of comes as is it chicken or the egg, right? So is it the drug causing the cancer, right? Is it the hypnotic agent causing the cancer? Or is it likely that this patient has a history of poor quality of sleep, which is likely the underlying reason, hence the increased risk for cancer, which ties back to square one, the beginning of the lecture here, talking about night shift work and the probable carcinogen risk there to humans. So that is one final takeaway. And the other final takeaway here, a recent 2021 network meta-analysis conclusion stated that the DORAs or the auras can be widely used in adults and the elderly, and both short-term and long-term use are effective for primary insomnia. Antihistamines are more effective in adults than the elderly. Although benzodiazepines have a more obvious effect on sleep maintenance, it's best to reduce their use due to side effects, especially for the elderly. As a food supplement, melatonin has little effect on adults, but it still has a certain effect on the elderly. So still lots to go out there with sleep, but the newest drug class, again, those DORAs, I think will be a new pathway and potentially a future cornerstone for sleep health. So that is it, and I hope that you learned a little bit about sleep and sleep agents.